I want to ask you something before we go any further. You have been managing your diabetes carefully. You check your glucose. You watch what you eat. You take your medication on schedule. You have given up foods you loved. You have spent money on monitors and supplements and special products. You have done everything you were told to do. And your morning numbers are still all over the place. Tuesday, 192. Wednesday, 174. Thursday, 208. Same dinner, same medication, same routine. And yet the numbers keep doing something you cannot predict and cannot explain. If that pattern sounds familiar, I want you to stay with me for the next few minutes. Because what I am about to share is something that almost never comes up in a diabetes appointment, and it may be the missing piece that nobody has thought to look for. It is not a new medication. It is not a different diet. It is not a supplement. It is water. Specifically, when you drink it, how much you drink, what temperature it is, and what you put in it. And before you close this out thinking that sounds too simple to matter, I need to tell you about what water actually does inside the cells of a diabetic body over 60. Because the biology here is not simple at all. It is specific, it is measurable, and it directly explains why so many people who are doing everything right are still getting numbers that make no sense. My name is Dr. William Madison. I have been in clinical practice for more than 20 years, and what changed my entire approach to treating diabetes in older adults was not a new drug or a new technology. It was noticing that a large portion of my patients over 65 were chronically dehydrated. Not occasionally dehydrated, chronically, persistently, every single day dehydrated. And that dehydration was creating a cascade of metabolic problems that made blood sugar control nearly impossible, regardless of what medication they were on or how carefully they managed their diet. Today I'm going to explain exactly why this happens, walk you through the 3 mistakes almost every older adult with diabetes is making with hydration right now, and give you a specific 4-window drinking protocol that has produced real, measurable improvements in fasting glucose for patients who had been struggling for years. But first, I need to explain 4 changes that happen in the body after 60 that nobody told you about, because without understanding these, the rest of this will not make complete sense. The first change happens in the tiny channels that move water into your cells. Your body has proteins called aquaporins that act like doorways, allowing water to pass from your bloodstream into the cells that need it. As you age, these channels become less responsive. This means that even when you drink water, your cells have a harder time actually pulling that water inside where it is needed. You can be drinking what feels like a reasonable amount and still be running at a cellular level deficit. The second change happens in your kidneys. By the time most people reach 70, their kidneys have lost approximately 30% of their filtering capacity compared to what it was at 40. This affects blood sugar in 2 ways. First, the kidneys are less effective at removing excess glucose from the bloodstream. Second, they become less efficient at conserving water, so you lose more fluid than you should through urination, even when you are not drinking enough to replace it. The third change is one that catches almost everyone off guard. Your sense of thirst becomes significantly impaired as you age. Research shows that by age 65, the thirst response can be delayed by up to 90 minutes after the body actually needs water. This means you can be clinically dehydrated, with measurably low cellular water levels, and feel no sensation of thirst whatsoever. The warning system is broken. Your body is running low and not alerting you. And because you do not feel thirsty, you do not drink. And the dehydration deepens quietly and invisibly. The fourth change involves medication. Many people with diabetes also take diuretics for blood pressure. Diuretics work by pulling water out of the body to reduce fluid volume and lower pressure. That is exactly what they are designed to do. But in an older adult who is already struggling to maintain adequate hydration because of the 3 changes I just described, a diuretic adds another layer of water loss to a system that is already running dry. Now let me explain what dehydration actually does to blood sugar control, because this is the mechanism that most diabetes conversations never address. When your cells are dehydrated, even by as little as 3%, the cell membrane, the outer wall of the cell, becomes rigid. Think about the difference between a damp sponge and a dried-out sponge. A damp sponge absorbs liquid easily and immediately. A dried-out sponge resists it, hardens against it, and only slowly begins to soften even when you hold it under running water. Your cell membranes behave exactly the same way. On the surface of your cells are insulin receptors. These receptors are what allow insulin to connect with the cell and signal it to let glucose in. When cell membranes are properly hydrated and flexible, insulin receptors function normally. When cell membranes are rigid from dehydration, those receptors stop working efficiently. They cannot do what they are supposed to do. And here is what that means in practical terms. Your pancreas can be producing insulin. You may be injecting insulin. You may be taking medication designed to help insulin work better. But if your cell membranes are rigid and your receptors are impaired, the insulin cannot deliver the glucose into the cell. The glucose stays in your bloodstream. Your reading climbs. Not because you ate wrong, not because you missed your medication, because your cells physically cannot accept what is being offered to them. I want to tell you about a patient I will call Raymond. He was 69 years old. His diabetes had been stable for 8 years, controlled and predictable. Then, without changing anything he could identify, his morning readings started going wrong. He had been waking up to numbers between 110 and 120 for years. Suddenly he was seeing 175, 185, occasionally breaking 200. His daughter brought him in because she was frightened and frustrated. She helped him prepare his meals. They weighed everything. His dinner the night before a high reading was identical to his dinner the night before a normal reading. I went through his day hour by hour. Food timing, medication schedule, exercise, sleep, everything looked correct. Then I asked him to describe his fluid intake for a typical day. He had coffee when he woke up, a glass of water with his morning medications, sometimes iced tea in the afternoon, another glass of water with dinner. When I pressed for specifics about plain water, he said he probably had about 2 full glasses during the day. He added that he was never really thirsty, so he did not think about it much. At his body weight, Raymond needed approximately 90 ounces of water per day. He was consuming somewhere around 16. He was chronically dehydrated without a single moment of feeling thirsty, because his thirst mechanism had aged past the point of reliability. And his daily coffee, which he counted as fluid, was actually working against him. For every 8 ounces of coffee consumed, the net hydration benefit is only about 3 ounces, because coffee causes increased urination that pulls from the body's existing water stores. We changed one thing. We restructured when, how much, and at what temperature he drank water throughout the day. Nothing else changed. Same food, same medication, same everything. 10 days later, Raymond sent a message. His tone was completely different from the exhausted, confused man who had sat across from me. His morning reading that day was 118. The day before, 124. 3 days before that, 132. He had not seen numbers like that in 6 months. At 4 weeks, his average fasting glucose for 2 straight weeks was 127, down from 185. Same food, same medications. One variable changed. He told me something else that I want you to hear. He said he felt less foggy, that there had been a mental haze he had gotten so used to that he stopped noticing it, and now it was gone. That is what happens when a brain that is 75% water finally gets consistently hydrated after running depleted for months. The clarity comes back. The fog that felt like a symptom of age was partly a symptom of dehydration. Before I walk you through the exact protocol, I need to address 3 mistakes that almost every older adult with diabetes is making with hydration right now. I would estimate you are making at least 2 of them. The first mistake is counting coffee, tea, juice, and other beverages as water. Here is the truth. Coffee and regular tea are mild diuretics. For every 8 ounces you drink, you net approximately 3 ounces of actual hydration, because the rest is cleared through increased urination, pulling from your body's existing water stores rather than adding to them. If you are drinking 3 cups of coffee and calling that 24 ounces toward your daily fluid goal, you are actually in a net deficit of around 15 ounces just from the coffee. Juice, even unsweetened juice, causes rapid blood sugar spikes that trigger your kidneys to dump both glucose and water into the urine. Diet sodas contain artificial sweeteners that research suggests may worsen insulin resistance over time. Plain water is the only beverage that genuinely hydrates. Everything else is supplementary at best and counterproductive at worst. Think of it like a bank account that needs $1,000 to avoid fees. If you deposit $1,000 knowing the bank will immediately withdraw $600, you are still $400 short. That is what coffee and juice do to your hydration account. The second mistake is drinking cold water, especially first thing in the morning. This one surprises people because cold water feels refreshing, particularly in the morning when you are waking up slowly. But here's what actually happens biologically when ice-cold water hits your stomach, especially when your body temperature is still lower from sleep. Your blood vessels constrict immediately. This is your body's reflexive response to the cold, attempting to maintain your core temperature. When blood vessels constrict, circulation decreases. And here's the problem with that for blood sugar. Glucose needs to travel through your bloodstream to reach your cells. Insulin needs to travel through your bloodstream to reach its receptors. When circulation is compromised by vascular constriction, both insulin and glucose cannot reach their destinations efficiently. Additionally, cold water on an empty stomach triggers a mild stress response. Your body interprets the shock of cold as a stressor and releases cortisol as part of the response. And cortisol has a direct and well-documented effect on blood sugar. It signals your liver to release stored glucose into the bloodstream. You have now created a blood sugar rise before you have eaten a single thing, simply from the temperature of the water you drank. Room temperature water, or ideally slightly warm water, keeps blood vessels relaxed and open. Circulation stays optimal. The stress response is not triggered. Your morning blood sugar environment starts from a calmer, more stable baseline. The third mistake is waiting until you are thirsty, and then drinking a large amount all at once. Remember what I said about the aging thirst mechanism. By the time you feel thirsty at 65 or older, you are already meaningfully dehydrated. So many people's response when they finally feel the signal is to drink 16 or 20 ounces quickly, believing they are catching up on what their body needs. But your intestines can only absorb approximately 8 ounces of water every 20 minutes. Anything beyond that passes through to the bladder without being absorbed by your cells. You have not hydrated your body. You have simply produced urine. The cells are still dry. Drinking a large amount all at once to compensate for hours of underdrinking is like trying to water a garden with a fire hose. The ground cannot absorb water at that rate. It runs off the surface while the roots underneath stay dry. Consistent, small, timed amounts throughout the day are what actually reach the cells that need them. Now let me give you the specific protocol. I call it the WTR protocol. W for water itself, used strategically and prepared correctly. T for timing, the specific windows that produce the most significant blood sugar benefit. R for regulation, the adaptation phase your body goes through as it recalibrates to consistent hydration. Let me start with the water itself. Plain tap water is adequate if your local supply is clean, but I recommend filtered water when possible. Not because of dramatic contamination concerns, but because of what you are going to add to it. Your cells do not just need water molecules. They need electrolytes, the minerals that create the electrical gradients that allow glucose to enter cells. Think of minerals as the keys that unlock the cell doors. Water without adequate minerals is like having the water but not having the key. It cannot get fully where it needs to go. The three minerals most relevant to blood sugar control in older adults are magnesium, potassium, and sodium in appropriate balance. Magnesium is critical for insulin function, and research suggests that nearly 70% of adults over 60 are deficient in it. Potassium helps regulate glucose levels. Sodium in appropriate amounts is essential for cellular hydration. The simplest and most cost-effective way to address this is liquid trace mineral drops, available at most health food stores and pharmacies for around $10 a bottle that last for months. Add 5 drops to every 32 ounces of water you drink. That is the entire preparation. Simple, inexpensive, and it makes a meaningful difference to whether the water you drink actually reaches your cells. Now let me walk you through the 4 timing windows that structure the protocol. The first window is immediately upon waking. Before coffee, before breakfast, before checking your phone, before anything else. Drink 12 ounces of room temperature water with your mineral drops. 12 ounces, room temperature, with minerals. That combination matters. After 7 to 8 hours without fluid intake, your blood has thickened overnight. It is literally more concentrated and more viscous than it was when you went to sleep. This makes circulation less efficient and makes it harder for insulin to reach its receptors and for glucose to enter cells. 12 ounces of room temperature water at this moment begins thinning the blood back to its optimal viscosity, improving circulation, and preparing your cellular environment for the glucose that breakfast is about to introduce. There is also a specific effect on what is called the dawn phenomenon, that frustrating morning blood sugar rise that seems to come from nowhere even before you eat. The dawn phenomenon is partly driven by cortisol, which rises naturally in the early morning hours as your body prepares for the day. Drinking water immediately upon waking signals your hypothalamus, the part of the brain that regulates metabolism, that the body is being cared for. This gentle metabolic activation appears to moderate the cortisol-driven glucose release that causes the dawn rise. In patients who implement only this single step, morning glucose commonly drops by 25 to 35 points within 2 weeks. From 12 ounces of water at the right time, That is not a small effect. That is clinically meaningful. The second window is 30 minutes before each meal. Drink 8 ounces of water exactly 30 minutes before breakfast, 30 minutes before lunch, and 30 minutes before dinner. The timing precision here matters. Not 15 minutes before, not right before you eat. 30 minutes. Here is why the 30-minute window is specifically effective for blood sugar. When water reaches your stomach 30 minutes before food arrives, it activates the preparation process. Digestive enzymes are stimulated. The stomach begins producing the right concentrations of acid for breaking down the food that is coming. The stomach lining prepares to receive. Most importantly for blood sugar, water consumed 30 minutes before a meal slows what is called gastric emptying, which is the rate at which food moves from your stomach into your small intestine. When food moves more slowly from the stomach to the intestine, carbohydrates are digested and absorbed more gradually. Instead of a wave of glucose hitting your bloodstream all at once and overwhelming your available insulin, the glucose arrives in a slower, steadier stream that your insulin can actually keep pace with. The spike is blunted. The peak is lower. The recovery is faster. Research examining this specific timing has found that pre-meal water consumption can reduce post-meal glucose spikes by up to 35%. That is a reduction comparable to some medications, achieved purely by the timing of when you drink 8 ounces of water. The third window is mid-morning and mid-afternoon, specifically around 10:30 in the morning and 3:30 in the afternoon. This addresses something that confuses many people with diabetes. You are between meals. You have not eaten anything for 2 or 3 hours. You check your glucose, and it has climbed 15, 20, sometimes 30 points for no apparent reason. No food entered your body. Why is the number higher? Here is what is happening. Your blood is losing water continuously through normal metabolic processes, through breathing, through skin evaporation, through minor perspiration. As blood loses water, it becomes more concentrated. More concentrated blood contains the same amount of glucose in a smaller volume of fluid. The concentration of glucose per unit of blood goes up. Your monitor reads a higher number, not because glucose entered your system, but because the fluid that was diluting it left. Drinking 6 to 8 ounces at 10:30 and again at 3:30 maintains blood volume and prevents this concentration effect during the hours between meals. Small amounts. Strategic timing. Your readings during these windows become noticeably more stable. The fourth window is 2 to 3 hours before bed. Many people have heard not to drink water close to bedtime because of nighttime bathroom trips. That concern is valid. Drinking 10 ounces at 10 o'clock and going to bed at 10:30 will likely wake you at 1 in the morning, needing the bathroom, which disrupts the sleep that blood sugar control depends on. But the answer is not to stop evening hydration. The answer is to time it correctly. Drinking 8 ounces 2 to 3 hours before bed, say at 7 or 7:30 if you sleep at 10, gives your body time to process and distribute that water fully before you lie down. You will likely urinate once before bed. Then your body will have adequate hydration to work with throughout the overnight hours. This matters specifically for fasting glucose, because overnight dehydration concentrates the blood progressively as you sleep. By the time you wake up, the combination of overnight blood thickening and the natural cortisol rise of the early morning creates the conditions for high fasting readings. The evening hydration window reduces overnight blood concentration and gives you a better baseline to wake up to. Now I want to tell you about a second patient, because I think her story will resonate with anyone who has felt like they were losing a battle they had been fighting for a long time. She was 73 years old. She had managed type 2 diabetes for 16 years. When she came in, she was not just worried, she was defeated. Her endocrinologist had told her she needed to start insulin. Her HbA1c had climbed from 7.8 to 8.9 in 6 months. She was already on 3 oral medications. She sat across from me and told me she was terrified of needles, and that the thought of injecting herself multiple times a day felt like a kind of defeat she was not sure she could handle. I asked about her water intake. Total daily fluid consumption, approximately 20 ounces, most of it coffee and tea. Her urine was dark amber. Her skin had the papery, slightly dry texture of chronic dehydration. She reported constant fatigue that she had accepted as part of aging. When I explained the protocol, she looked at me the way most people look at this information the first time, with polite skepticism. Water? That is the answer? She had spent 16 years managing carbohydrates to the gram, attending education classes, trying every medication her insurance would cover. And I was telling her to drink water on a schedule. She agreed to try it because she was willing to try anything. The first week was difficult. She sent me a message on day 4 telling me she felt like she was living in her bathroom. I told her that was expected, that it was temporary, and to push through. By the second week, things shifted. The bathroom trips were normalizing. She told me she had slept through the entire night for the first time in months, and her morning reading that day was 148. It had not been below 175 in half a year. At her 3-week follow-up, her average fasting reading for the week was 139. Her post-meal numbers were rarely exceeding 165. Before the protocol, she had been regularly hitting 220 and 230 after meals. At the 3-month mark, her HbA1c had dropped from 8.9 to 7.7. Her endocrinologist called me. He said he did not know what I had done but to keep doing it, and that they were holding off on insulin. At the 6-month mark, her HbA1c was 7.2. The insulin conversation was permanently off the table. She told me something near the end of that conversation that has stayed with me. She said she had spent 16 years meticulously managing every complex aspect of her diabetes: the food, the exercise, the medications, the monitoring, everything except the most fundamental thing her body needed. She said she had been running an engine on empty and expecting it to perform perfectly. Now let me give you a realistic picture of what to expect week by week when you begin this protocol. In the first week, the most prominent experience will be increased bathroom trips. I am not going to soften this. It is the part that causes most people to quit, and quitting in week 1 means never experiencing what happens in week 3. Your body has been operating in a drought state, sometimes for months or years. It has adapted to function with less water by concentrating urine more aggressively, suppressing thirst signals, and keeping cells running at a lower hydration level. When you suddenly start providing consistent water, the body's first response is to test whether this is reliable. It passes a lot of fluid. It is recalibrating. This is normal, and it is temporary. Blood sugar changes in week 1 are modest, typically 5 to 10 points lower on average. Noticeable but not dramatic. In the second week, bathroom frequency begins normalizing significantly. Most patients tell me that by day 10 or 11, the urgency has decreased and trips are approaching normal frequency. Blood sugar readings during this week begin showing more consistency, meaning the gap between your highest and lowest daily reading starts narrowing. The variability, that baffling unpredictability, begins to reduce. The third week is where most people have what I would describe as their breakthrough moment. Morning fasting glucose drops noticeably, commonly 15 to 25 points below the previous average. Post-meal spikes become less dramatic and more predictable, and the non-glucose changes become evident. Mental clarity improves in a way that most people describe as the lifting of a fog they had stopped noticing was there. Afternoon energy crashes become less severe. Some patients notice reduced joint discomfort, which makes sense because chronic inflammation is worsened by dehydration. By the 4th week and beyond, blood sugar control continues improving as the body completes its recalibration to consistent hydration. Many patients see their HbA1c drop by half a point to nearly a full point over 3 months. Some, under their doctor's supervision, are able to reduce medication dosages as their cellular response to insulin improves. Before I close, I need to address some important medical considerations, because this protocol is not appropriate for everyone without modification. If you have congestive heart failure or any condition where your doctor has specifically told you to restrict fluid intake, you must speak with your cardiologist before increasing how much water you drink. In certain cardiac conditions, additional fluid intake can worsen fluid retention and put dangerous strain on the heart. This protocol in its standard form is not appropriate for you without medical clearance. If you have kidney disease, particularly if your kidney function is significantly reduced, or if you are on dialysis, increasing water intake without specific guidance from your nephrologist is not something I would recommend. The kidneys filter fluid, and a damaged filtering system requires a personalized approach to how much fluid is appropriate. If you are taking diuretic medications for blood pressure or heart conditions, be aware that proper hydration can naturally lower blood pressure. As your hydration improves, your current diuretic dose may become more than necessary, and your doctor may need to adjust it. This is a good problem to have, but it requires monitoring. Watch for signs of overhydration, though this is genuinely uncommon. If you are producing completely clear urine more than 10 times per day, or if you develop unexplained headaches or nausea, you may be slightly overdoing it. Reduce your intake slightly and check in with your doctor. For everyone else, for the majority of adults over 60 with type 2 diabetes who are frustrated by inconsistent readings despite doing everything right, the protocol is straightforward. Immediately upon waking, 12 ounces of room temperature water with trace minerals before anything else. 30 minutes before each meal, 8 ounces of room temperature water with minerals. Mid-morning around 10:30 and mid-afternoon around 3:30, 6 to 8 ounces at each window. 2 to 3 hours before bed, 8 ounces. Filtered water when possible. Trace mineral drops at 5 drops per 32 ounces. Room temperature, not cold. And stop counting coffee and other beverages as water in your daily total. That is the entire protocol. Nothing exotic, nothing expensive, nothing that requires a prescription or a clinic visit to begin. What it requires is consistency and the patience to push through the first week when the bathroom trips are annoying and the blood sugar changes are still modest. Because what is happening in that first week is not failure. It is your body beginning a recalibration that, if you stay with it, produces changes that 16 years of perfect diet management, careful medication adherence, and continuous glucose monitoring could not produce on their own. Sometimes the thing that is missing is not the most complicated thing. Sometimes it is the most fundamental one. If this gave you something useful today, I want to ask you to do one specific thing. Think of one person in your life who is managing diabetes and struggling with inconsistent readings despite doing everything right. A parent, a friend, a partner, someone whose glucose log shows numbers that make no sense given how carefully they are managing everything else. Send this to them today, not as a general share, as a direct message to a specific person whose face you pictured while reading this. Because the information that changes an outcome is only valuable when it reaches the right person before they have given up on finding a missing piece. I'm Dr. William Madison. Take care of yourself, take care of the people around you, and I will see you in the next video.